All right, Jonathan, whenever you're ready.
Okay, so welcome everybody. We're so glad to welcome you back. This is a really exciting opportunity. We are so excited to be part of the REC Colloquium Series here at the Boston University ADRC. It is my distinct pleasure to introduce an old colleague of mine. We were just talking, and it turns out we haven't seen each other in 3 years, which seems criminal. Dr. Beth Mormino. I'm going to read her bio, and then I'm just going to let her do her thing. I don't think you'll be disappointed. She's always got the best data. So Dr. Beth Mormino is a neuroscientist that applies imaging techniques in normal older adults to understand the neural correlates of cognitive changes that occur in early Alzheimer's disease and human aging. She completed her PhD in neuroscience at UC Berkeley in the laboratory of Dr. William Jagist, where she performed some of the initial studies applying amyloid PET to clinically normal older individuals. During her postdoc with Drs. Risa Sperling and Keith Johnson at Massachusetts General Hospital at that other ADRC, she investigated longitudinal cognitive decline in preclinical AD. In 2017, Dr. Mormino joined the faculty at Stanford University in the Department of Neurology and Neurological Sciences. Dr. Mormino, it is such a pleasure to have you here. Welcome to the BU ADRC, and thank you so much for being one of our speakers. Take it away.
Thanks, Jonathan. Yeah, thank you for the invitation. It's so nice to be invited to these sorts of events. And yeah, so I don't know what the custom is for this series, but I'm totally okay if anybody wants to interrupt with questions as we go. I'm on my small laptop, so I am not going to be paying attention to chat and hand raises. So if you can just, if Jonathan can either tell me something is happening, or if just you can just directly speak and ask a question, that is fine with me. So I'm going to talk about essentially amyloid and tau imaging in the context of kind of normal aging. I'm going to start with a very kind of a brief background. I know you guys are experts in Alzheimer's disease. I'm going to just touch on a couple of concepts and also talk about the kind of common applications of PET imaging right now in the context of Alzheimer's disease. And I know this is going to be mostly background for most of the people on Zoom right now. And then I'm going to go over kind of data with amyloid and tau PET in aging cohorts that have really kind of contributed to this concept of preclinical Alzheimer's disease, which is the main focus of my research program. I'm hoping to kind of highlight a couple consistent findings that have been in the literature kind of spread out over the last 15 years, some of my work and some others. And then I'm going to spend the last chunk of time really kind of highlighting some recent analyses that we've done, looking at issues with generalizability in the PET data sets that we've collected. So that's kind of an overview of what I would like to touch on. So yeah, as you guys know, Alzheimer's disease, it's a neurodegenerative disease, usually begins with episodic memory. I'm going to talk a lot about amyloid PET, and the reason for this is that this is kind of the predominant hypothesis of the disease, that it is somehow initiated by beta amyloid. Of course, there's a lot of controversy around this idea, but it is kind of the dominant hypothesis, as you guys know. There's obviously additional changes that are important that I'm going to talk about during this talk. Importantly, and this is kind of the main focus of my research program, is that there is this long asymptomatic stage of the disease. So the changes associated with Alzheimer's disease, we know are beginning probably decades before actual clinical dementia is present. Excitingly, we can visualize some of these changes using in vivo tools such as PETs. We can also measure them with biofluids like CSF and more recently plasma. And autopsy work has been done in this space to characterize the prevalence of these different pathologies associated with Alzheimer's disease, for decades. And importantly, there's no disease modifying treatment for this disease. So as you guys know, we have beta amyloid plaques. We also have accumulations of the tau protein into tangles. These are kind of considered the hallmark pathological features of the disease. Interestingly, for amyloid, it tends to be quite distributed spatially. For tangles, it tends to start in the medial temporal lobe, specifically entorhinal cortex before spreading to other limbic areas, and then eventually other parts of cortex. We have a very poor understanding of why there's such a dramatic kind of spatial non-overlap between the two hallmark pathologies. But importantly, as I mentioned, and as many of you study, we know that both these hallmark features, begin well before any sort of symptom of dementia is present, and even well before something like MCI would be diagnosed. So specifically, here's just a large meta-analysis that looked at a variety of studies that measure amyloid, and it shows this very striking pattern that within the normal group, which is shown here in the darker lines, we do see this kind of dramatic age effect, such that as individuals enter older ages, there's a large chunk of folks that would be considered what we call amyloid positive. So amongst 70-year-olds, that's probably about 25% or so would be considered amyloid positive. And then when we think about amyloid positivity in kind of healthy, normal individuals, it's also noteworthy that the distribution is quite dramatic even in the early stages. So this amyloid signal tends to be kind of almost everywhere throughout association cortex. We also expect, and we know from the postmortem literature, that tangle pathology is also extremely common amongst normal older individuals. So here's kind of a cartoon schematic showing what we expect in terms of the prevalence of tangle pathology. So green is what we'd expect from the entorhinal cortex. And as you can see, even before we expect abnormalities in amyloid, we tend to, we expect that the majority actually of older folks will have some degree of tangle pathology in entorhinal cortex, and that this increase is likely happening during middle age. This orange line is just giving a reference point to when we would expect abnormalities in amyloid, which is this global kind of phenomenon. And then lastly, neocortical tau, in terms of folks that are clinically normal, we don't expect a high degree of extensive tau pathology. And we expect kind of that the signal when it's leaving the medial temporal lobe into more adjacent limbic structures to really precede this kind of amyloid phase. So this is just a kind of a brief overview, kind of highlighting that, one, we do expect to see, some degree of AD pathology in people that technically have kind of normal cognition, and that the spatial patterns are quite different. So we do expect to see, diffuse distributions of abnormal amyloid levels, whereas the tangles are probably very focal at these beginning stages. And it's not until you actually start seeing symptoms that you would expect there to be extensive involvement from tangles and tau accumulation. This is just a kind of a brief background slide showing, just highlighting kind of the potential for PET in the context of AD. So I'm going to pretty much spend the whole talk talking about two different PET approaches. So one is amyloid PET, the other is tau PET, which both have their nuances kind of within those two spaces. But I just want to point out that there's also other PET ligands that can potentially tap into other aspects of the AD cascade. And that's part of the reason why PET imaging is such an exciting tool. So with PET imaging, you theoretically can make a drug, a ligand that's radioactive, that is able to be detected in the context of PET. And that target could theoretically be for anything in the brain. I mean, of course, it's very difficult to develop these ligands, these drugs, but there is such great potential for targeting various aspects of the aging brain and different targets that are relevant for disease. And I think this is something where we're really going to see a lot of advancements in this space over the next 15 years with non-amyloid and tau targets. But in the context of AD, so here's just one kind of idea of the sequence of events as kind of communicated by the amyloid hypothesis of AD, where we think that amyloid accumulation is starting early, and that somehow causes the spread of tau from the medial temporal lobe into cortex. And then we also know that there's probably synaptic dysfunction and also inflammatory processes that happen. And then eventually there's dementia. And so theoretically with PET, especially if we had better ligands for other targets, we could presumably measure these different steps of the cascade using different PET ligands. So I think that's something that's quite exciting about this modality. in particular. I'm also just going to point out that when we tend to think of amyloid and tau PET as shown over here, we kind of think of those as being very disease specific markers. These other PET ligands, so for instance, there's ligands that tap into inflammation. There's ligands like FDG PET that will tap into glucose metabolism. Those are probably related to many different underlying processes. So we would consider those to be probably less specific for Alzheimer's disease, but they may be critical for actually dictating who will actually express clinical symptoms of the disease. FDG has been around for a while. Inflammation target or PET scans that target inflammation have also been around for a while, but there's a lot of kind of issues with these ligands, so they haven't really taken off in the way that amyloid and tau PET does. But there are numerous research programs that are really focused on trying to target different aspects of inflammation that may be relevant. And then importantly, especially for this talk, these changes, as I've been emphasizing, occur well before overt dementia is present, which gives us the opportunity to use these tools to characterize the early stages of the disease. So the pros of PET imaging is that we're able to target very specific aspects kind of within the brain related to the disease. We're also able to get a spatial distribution, which is probably not as important for amyloid PET, but certainly for tau PET. The cons are also kind of obvious. So these scans are very expensive. So it's typically about 3,000 or so, and that's the research rate. So it's actually unclear how much it would cost in a clinical setting if they were to become available or covered by insurance companies. It would probably be much more. And then there's radiation exposure. And a lot of these cons, definitely it's a huge limitation for the utilization of these scans. And I think, also has a great potential to cause a lot of bias, into these studies because of that. But the strengths are definitely in the specificity and our ability to look at the spatial distribution of these key features of Alzheimer's disease. So I'm going to go, as part of the background, I just want to highlight just a couple kind of main concepts related to the utilization of PET. So as you guys know, there's a number, so amyloid PET has been around since 2005. The first kind of promising ligand was PIB, and that's when those research studies were initiated. And since then, there have been 3 very promising F18 labeled amyloid PET scans that the approval happened in between 2012 and 2014 that all are very highly correlated with PIB PET, and also have been shown with kind of hospice style analyses that the signal during life is highly correlated with the signal at death. So these have all been approved by the FDA to be able to kind of order a scan and also to communicate to an individual that they have evidence of underlying amyloid pathology in their brain. So that's kind of interesting. These are not being used clinically now because insurance companies are not covering them, which is in part related to the fact that we don't have any drugs. So it's really the clinical utility of this is unclear. But it is interesting that these things, are technically approved for the visualization of amyloid plaques in the brain. Sorry, was that a question? No, I think I just heard a beep. And then very recently, we have seen the first FDA approval for tau PET. Tau-vid, which was formerly probably most well known as AB 1451, recently went through the same procedures, and so we're just recently seeing the very first approval of actual tau ligands. So this one ligand in particular has been approved, to be able to tell an individual that they have evidence of tangle pathology in their brain based on the pattern of the PET scan. Another, widespread use of amyloid PET. So it's not used clinically right now because the clinical utility is quite unclear in the absence of a treatment. But it is pretty much consistently now used in clinical trials, both for the selection of patients to confirm that they have underlying amyloid pathology. And this is mostly in the context of anti-amyloid therapeutics. And it's also been used as a a way of assessing treatment. So for instance, in anti-amyloid clinical trials, you would want to know, is your drug actually doing anything to the target? And amyloid PET has provided the ideal opportunity for companies and trials to be able to just investigate that directly. And as you all, aducanumab has gotten a lot of attention. It's very controversial right now in terms of whether or not their trials, were successful. They ended up stopping their trials early, but then tried to make an argument that there was a clinical benefit. So that is a controversy right now. But what has become clear is that from the biomarker side, it's clear that these drugs are removing amyloid from the brain. The problem with this is we don't actually know if that's meaningful or not. But this is something that is a clear widespread use of amyloid PET right now, to use both for the selection of participants and also to determine whether or not the drug is actually crossing the blood-brain barrier and doing what we think it's doing. And then I also want to highlight this is I think my last background slide, but another thing that's becoming increasingly common, especially led by Risa Sperling over at MGH, is this concept of using amyloid PET for early detection and then to enroll amyloid positive individuals that are clinically normal into prevention trials. And so I think this is a quite exciting thing in the field right now, both in that these trials are extremely complicated and long, and that they're actually happening right now. And there will be these specific results that are presented related to this concept of early intervention. So in all these example trials, older individuals are being enrolled into an anti-amyloid infusion trial based on essentially their PET scan. So this is really a big change in the clinical trial space. And as you know, so the A4 study should be completing. The enrollment has been completed for some time, and the actual results will be finalized very soon. The early study was actually canceled early because of side effects, so that was quite disappointing. And then the next kind of big trial that has just been initiated is also recruiting these amyloid positive normal controls. So this is something that we are starting to see the first kind of attempts at the concept of using amyloid PET to identify at-risk people and then see if an early intervention is helpful. Okay, so I'm gonna shift into some more kind of specific research data. So as I mentioned a couple times, so we know that there's going to be a subset of normal older controls that have abnormal amyloid. Here's what these scans look like. So typical amyloid negative is going to be has a quite low signal. The cooler colors reflect low binding. A typical amyloid positive scan would have this kind of robust signal spread out over cortex, which matches what we expect from the postmortem literature. And so notably, this is a normal control who's amyloid positive. In comparison to this amyloid negative scan, it's obviously quite different. And then here's an amyloid positive patient with dementia. So it is quite interesting that, from the scan perspective, these two individuals are quite similar. Except for one has dementia and one is completely normal. When we do these sorts of studies in large cohorts of normal controls, so this is data from the Harvard Aging Brain Study, we pretty much consistently see that there's this subset of normal controls that really show this robust elevated signal, and that the percentage will just depend on the age of the cohort. This is in contrast to individuals with MCI, which MCI tends to kind of fill the continuum of values, with some individuals that clearly have an impairment due to some non-amyloid process, and then others that look more like AD. And then within the AD group, we typically expect most people to be amyloid positive, but probably 10 to 20% or so to be amyloid negative, which some people would consider that to be just a misdiagnosis, that perhaps their dementia is due to some other non-amyloid cause. And so I'm not going to go into, this is kind of some old literature, but given the fact that there is this large proportion of otherwise healthy, normal individuals that have this evidence of early amyloid positivity, 10 years ago or so, when this was kind of a more new concept, we were very interested in understanding what are the initial consequences of being amyloid positive. Do amyloid positive normals, do they have evidence of these early changes? And for the most part, that tends to be the case. So this is some of my work from my dissertation at Berkeley, but many people have looked at similar concepts. And essentially what we tend to find is that if you are amyloid positive and normal, you do tend to show some differences in functional imaging that is indicative of what we know happens in Alzheimer's disease. So in these two example studies here, we found that there was reduced connectivity throughout the DMN. We do know that the DMN seems to be quite important for Alzheimer's disease and aligns with a lot of the hub areas that amyloid deposits. We also found evidence of increased functional activation during memory coding in amyloid positives that we attributed to this pathological burden. And many other people have found similar results, that even though these folks are completely normal otherwise, it does tend to be the case that they have these subtle differences in functional MRI, and also a little bit with structural data when compared cross-sectionally. And now that longer follow-up studies have been available, we've also been able to get closer to asking, if you are amyloid positive and normal at baseline, what actually happens to you over time? I mean, that's kind of the main question. Is this useful from a prediction standpoint to understand who's most at risk for actually progressing clinically? And I think this is a nice study that summarizes kind of the main punchline with amyloid PET. So this is looking at progression specifically on the clinical dementia rating scale. So this is trying to look at clinically meaningful change. And this is just simply asking, what is the time to progress to not being a CDR0? The orange plot is the orange curve is showing the amyloid positive group at baseline, the amyloid positive normals, and the blue is showing the amyloid negative normals. And what we do see is that there definitely is a statistically significant difference between the amyloid positive and negative groups. However, it takes about 4 years of follow-up for this to emerge, and still it's only about 35% of the amyloid positive group that will progress, not necessarily to dementia, but just to a CDR of above 0. So it could be a quite mild progression. And it isn't until about 8 years after follow-up that you really start to see that the majority of the amyloid positive group has progressed on the CDR. But again, this isn't dementia. This could just be a CDR of 0.5. So I think this has been a complication for the interpretation of amyloid positivity and normals, and something we all need to think about with our study designs, because both it does imply that, if you're amyloid positive, you're at higher risk for clinically meaningful change. However, the time course is probably quite long, and it really makes this unclear what this would mean to your typical 75-year-old if that comes in and gets an amyloid positive scan. What does it actually mean for that person, in their kind of expected lifespan to actually progress to dementia? So I think this is an interesting set of analyses, and it's a concept that as a field, I think that we're kind of struggling with. Okay, so I'm going to shift gears a little bit to the tau PET side. So for those of us in this space, I think it's a rapidly kind of changing space, and it's also, I think, quite confusing with all the different ligands. It's turned out that for tau PET, I think it's much more complicated than amyloid PET. With amyloid PET, it's such a robust global signal. I think the sites of off-target binding and the complications were just a little more addressable. And importantly, any sort of comparison across the ligands, even though there are some slight differences, for the most part, they give us the same punchline. They give us a nice, robust measure of whether or not somebody tends to be positive or negative. For tau PET, it's been a lot more complicated. The ligands are a lot noisier. And that has really also led to just the development of kind of multiple ligands, and then some ligands not working out, and then some coming forward. And this has really been unfolding, I would say, over the last 8 years or so, and especially the last 5 years. So this slide is really, I'm not going to go through all these ligands, but it's just kind of a summary of just when the ligands emerged, and kind of where we are now. So if we jump forward to present, so as I mentioned, we have had one tau PET ligand that's been approved, fluorotaucipir. So this is one of the earliest ligands. This was the kind of most promising ligand at the beginning, back in 2013. And then I would say in the last couple of years, there's been interest in both fluorotaucipir, and it's definitely the most widely used. PI 2620, that's what we've been using at Stanford. I'll present a little bit of data on that. That's kind of a newer ligand that I wouldn't necessarily say it's better than fluorotaucipir, but there are some characteristics of it that are interesting. And then MK6240 has also kind of been integrated into these newer studies. So I would say there's kind of 3 ligands that are being used now, but I wouldn't be surprised if in 5 years, there's a completely different set of ligands, given how rapidly this space has been changing. So regardless of the known issues with the different ligands and some of the complications, I think the work in understanding initial consequences in normal older individuals has been actually quite exciting. So again, here's 3 example cases. On the top is the individual's PIB scans. So this is similar to what I just showed you a few slides ago. But now here's the corresponding tau PET scans. Again, here's an amyloid negative normal, and we see very little uptake on the tau side. And then here's an amyloid positive normal, where we see this robust amyloid PET signal. But also we see this really nice signal in the medial temporal lobe extending into lateral, inferior and lateral temporal cortex. And this is quite exciting that we could, at least in some individuals, we can measure this kind of focal pathology as it's spreading. And then here's a typical AD dementia case where, again, we see this distributed amyloid PET signal and also a quite distributed signal when it comes to the tau PET signal as well. So I think, this is quite exciting, this ability to look at this early signal and to start asking questions, targeted questions about the signal within our aging cohorts. So this is an older study just kind of highlighting that when you look at MCI and AD versus normal controls, there's a really nice range of tau PET values and really large group effects. However, I think, the more interesting question is, this limited range within the normals, in particular in the medial temporal lobe, where we expect this signal to emerge, is this meaningful, and can we leverage this data to understand both mechanisms of memory change and aging, and also prediction regarding clinical change, clinical status in normal cohorts. So this is some of our initial work with tau PET in the HAB study. So here's just a voxel-wise map asking, where are the areas that show the greatest differences in the amyloid positive group compared to the amyloid negative group. That map is shown here. So we see these elevations in tau PET signal in the medial temporal lobe, and also extending into this kind of ventral temporal cortical region. So this is somewhat expected from the postmortem literature. And then also importantly, when we both combine amyloid status with this elevations in tau in the medial temporal lobe, we can start to ask questions about, how does this predict memory performance? So that's what's shown here. On the y-axis is a change in memory over time following the tau scan. At the time of this analysis, it was just about 1 year of follow-up. So this is really short-term memory change. And then tau in the entorhinal cortex is plotted on the x-axis, and then individuals are sorted by amyloid status. And what you can see is that, so for the most part, those that are elevated in terms of their tau signal, they all tend to be amyloid positive, as indicated by the red diamond. And then you also can see that in terms of memory performance, first, there isn't really that much change in memory. It's really driven by a couple subjects, but they do tend to be the subjects that are both amyloid positive and also have this kind of initial elevations in entorhinal cortex. So that's quite exciting, especially from the perspective of, we know that this the predictive value of amyloid alone is probably quite poor. The integration of things like tau PET might be able to help us actually identify the folks that are most at risk for future progression. So since this time, and there's been a number of cohorts that have looked at the relationships between amyloid and tau and memory. And I'm just going to highlight 3 studies to kind of summarize what I think the pattern is. So this is just what I went over from the HABS data. This is work from Wisconsin that is using a different tau tracer, the MK tracer. But they actually find the pattern is quite similar. So here they plotted the data a little different, but this orange line is effectively the folks that are both amyloid positive and tau positive. And you see there is this kind of age-related change in memory, whereas the other groups, if you're just amyloid positive, for instance, without being tau positive, they're effectively the same. So again, kind of highlighting that maybe the combination of these 2 measures might be relevant for understanding kind of initial cognitive changes. Here's another study from the Berkeley cohort. Here, the amyloid positives are shown in red and the amyloid negatives are shown in blue. So here they actually do see that elevated tau is associated with worse memory. So you can kind of imagine a negative regression fit here. However, they don't see this kind of modification by amyloid status. So here they actually do find individuals, these unfilled dots and this black and unfilled dot here, that are actually amyloid negatives that have this higher tau signal. So in this cohort, it doesn't seem to be as dependent on this amyloid relationship. So tau does seem to be an important predictor of memory decline or memory change, but it isn't as tightly coupled to the amyloid piece. So I think there's a little bit of a certainty about the amyloid dependency of these effects. But so far across, I think most of the cohorts that have examined this, it does seem to be the case that elevated tau signal within the medial temporal lobe does seem to be a poor, it does seem to track with worse memory performance. I'm going to say a few words about the spatial pattern of this. I've been getting quite interested in the cortical involvement of this early tau PET signal. So I just showed you a map from HABS that's showing here are the areas that are elevated in the amyloid positives. Here's the analogous map in the A4 data set, which is also a large data set of older normal individuals with tau PET. You can see a similar pattern with the medial temporal lobe and this ventral temporal cortex area, but you also start to see this kind of selective involvement of the angular gyrus as well in this cohort, which is much bigger than HABS. And then finally, this is from the Wisconsin group, a similar contrast looking at, where is tau elevated and amyloid positive normals. And again, they see this involvement of ventral temporal cortex and also angular gyrus with a little bit of the caudal middle and definitely the precuneus area here, which I'm not showing in these views. So I think this pattern in particular is quite interesting in terms of trying to think about how this might be influencing early memory change. So with that being said, we've been conducting some experiments, some fMRI experiments to try to get at this, where we just have some kind of a first round of preliminary data. But as I said, we've been kind of interested in like how involved the ventral temporal cortex is and also angular. And we know that these regions are both key regions for visual associative memory. So we know VTC is very important for these visual associative content specific aspects of memory encoding and retrieval, whereas angular gyrus is very critical for retrieval processes. So to make a long story short, what we've been doing, this is a collaboration I have with Anthony Wagner at Stanford, is we've been trying to get at these different mechanisms of memory that are important for these cortical regions. So in particular, the encoding patterns in both VTC and also angular during associative visual memory, and the degree to which these patterns are reinstated during the retrieval phase, which is known as cortical reinstatement and is thought to be a critical mechanism for successful memory. So we've been capturing that kind of overlap of activation patterns during encoding and retrieving, and then asking if that relates to this early tau burden, especially because these regions, like I said, really seem to be these like hot spots of where kind of cortical tau becomes elevated beyond the medial temporal lobe. And this is a very, it's kind of a sad scatter plot because there's just a couple points, but this is something that we're hoping to build. We're continuing to collect data and we'll be building over the next few years. But in short, we do see that both hippocampal activation during retrieval and also these measures of reinstatement of this kind of similarity of activation during retrieval and encoding, the ability to do that does tend to track with this medial temporal lobe tau, with the caveat that these are very small preliminary studies thus far. But I do think it's interesting to think of, this specific network. It's so key to visual associative memory in particular. It might be one of the earliest, an early consequence of this initial pathology in normals. I'm gonna, since I'm taking longer, I'm gonna actually skip this. Actually, I'll just say one thing about this. So the tau, tau PET, I think it has been, the signal has been quite interesting within normals, based on the data that I just showed. There are known issues with off-target binding. So in particular, the choroid plexus does seem to be problematic for AV1451. You can see kind of some examples here. And this is really, in particular, difficult for measuring the hippocampus, given that the choroid plexus is really sitting on top of the hippocampus. As I mentioned, kind of in the timeline of the different ligands, these issues with off-target binding have led to the development of these newer ligands. So I'm just going to show you briefly some data from our cohort using PI2620, which is one of these newer ligands. And we do tend to see, like, even though the choroid plexus actually tends to be a little less, although we do see some cases that have the choroid plexus, it tends to, for the most part, be not as bad as AV1451, but definitely still present in the oldest subjects, which we think has something to do with mineralization and aging. We do tend to see this uptake in the sinus area, and also in pigment containing regions as well. One kind of big difference between PI and AV1451 is we don't see a prominent basal ganglia signal, which is really prominent with AV1451, which might have something to do with iron. So I guess I would say if there are individuals that are trying to think about, what ligands to use in their studies, I mean, I don't think there's really a clear kind of winner. Like, there's some kind of issues with both of these guys. So I think it's really too hard to really make a definitive statement on there being one kind of optimal ligand at this point. Okay, so now I want to spend I have like 22 minutes. So I'm going to walk through some very recent analyses that we've been doing that I think actually call into question a lot of what I just presented. So what I will say is so I'm doing PET imaging ever since my PhD at Berkeley, which started in 2005. And there has been this one comment that I've always gotten in all my work, and that is the issue of generalizability and the issue with how homogeneous our cohorts are. So when we do these sorts of studies, it's really demanding. Individuals have to come for multiple days. They get injected with things, they have to sit in a scanner. So just from my own personal experience interacting with the types of subjects that volunteer for these studies, they're really just, they're very highly educated. They're just super interested in research. I mean, it's really a biased sample of folks that end up doing these studies and have been contributing data that we've been analyzing for the last 15 years or so. And this has always come up for me during the review process that, even though it's a nice set of findings and it tells us about early AD and we have correlations with memory, it's really unclear whether or not it generalizes at all. So recently we've started to look at this a little closer, not from the perspective of recruitment and designing studies, but just with the data in hand. Do we actually have any evidence that the data in hand, is telling us that things are not easily translating between populations? And so I'm going to present, this is more an example, I think, of the lack of generalizability that are in our current data sets, which I think is a huge problem. This is work that has been led by a postdoc in my lab, Casey Dieters, and this work, it will be coming out soon. But I think it's a really nice example of maybe some of the problems that are in our data sets. So as you guys know, in general, there's a lack of data, especially in the biomarker space, when it comes to more diverse populations. This is a huge problem, because we know that, for instance, in non-Hispanic Blacks, the risk of dementia is actually higher. So it's a huge mismatch to have missing data for a group that's actually at elevated risk for the thing you're trying to study. As I've kind of said, and I think most folks are aware of, minority populations in general are hugely underrepresented in studies of dementia, especially in things like PET studies. And I think, as a really also interesting example of why this is problematic is that we already know that there are differences in risk factors across different populations. So ApoE, I think, is a fascinating example. So ApoE, when we tend to think of ApoE, we tend to think of it as being, the most established, prominent predictor of AD risk and also of amyloid positivity. And this has been shown over and over again in our space. However, when you start looking at this, something that seems like such a simple risk factor, and you start looking at it in different populations, there's just differences in the way that it behaves as a risk factor. And so for individuals that are Black, for one, the frequency of the ApoE4 allele is much higher. So in normal aging cohorts, it would be about 35% compared to about 20% or so that we would expect in white populations. And also there's been a series of work that has suggested that the actual just risk associated with E4 is less in Blacks compared to whites. So it seems to be more common, but it also seems to be less of a risk factor. So this is, at the most superficial level, this is a really interesting example of how you can't simply take a risk factor that's been defined in one type of kind of cohort and just easily and kind of assume that it's going to have equal weight across, everybody. So what we kind of got interested in is, how do these factors, influence just something simple. ApoE is simple, and also amyloid PET is quite a simple variable. So we've been kind of probing this A4 data set, which I mentioned in the context of these clinical trials and also with the tau PET data. But effectively, the A4 data set, as you guys know, this is something that Risa Sperling has led. But the idea is to recruit like a huge sample of normal older adults, to screen them and kind of to classify them as being normal. If they're normal, they get a PET scan. If they're amyloid positive, then they then go into getting randomized into the clinical trial. One of the really nice things that that Risa and the other investigators did is that they made all this baseline data available. So even before, without any sort of exposure to drug, there's about five. There's actually these samples are a little reduced because they ended up having to recruit more. But it's effectively about 5,000 amyloid scans that have been collected to find the 1,500 or so that were positive that would go into the trial. So there's a fair amount of data that was generated through this exercise that's all on people who qualify for being clinically normal, that we can start to probe some of these questions. So I think one of the most interesting things that we've found, we've looked at amyloid PET in this large data set with respect to many different factors that influence amyloid positivity, such as ApoE and cognition and sleep. And actually, for the most part, ApoE always has a big effect, but all the other correlates are quite small. However, there's this huge effect of self-identified race in this cohort. So here I'm just plotting, just to keep it simple, 2 levels of ApoE, since we know that's a prominent risk factor for amyloid positivity. And then the individuals that self-identify as non-Hispanic Black are shown in purple. And then those that identify as non-Hispanic White are shown in blue. And you can see there's actually a 2-fold difference in these groups, such that the white population is twice as likely to be amyloid positive than the Black population. And this is something that is maintained across genotype. And it's a huge effect. It's a huge effect of having a reduced risk if you self-identify as non-Hispanic Black in this cohort. So if we look at this a little more closely, so what we also tend to notice is that amongst those that are scanned with amyloid PET that are non-Hispanic Black compared to white, There's differences in, there's a little bit of an age difference. There's a slight education difference, and also a difference in sex. So amongst the Black group, there's more females. So what we've done is we've created a demographically matched white group that's shown in the light blue here. And that actually effectively doesn't change the results at all. It's still the case that the non-Hispanic Black group has systematically lower levels of amyloid. And here I'm also showing this across all the different genotypes as well. So this is something that's consistent across pretty much all the genotypes. There is, in the E2 group, it's actually this weird reversal. So the Blacks actually have less of a protective effect of E2, which is what we typically expect in the white groups. You tend to have lower amyloids in the E2 compared to the E3, but actually in Blacks, it's the opposite. That certainly could be driven by the sample size, but it is kind of also another example of the lack of translation. So we were thinking about this effect, and then we also, remembered that, there is this huge confound related to screening. So the way that the A4 study works is first you undergo the screening visit to determine eligibility, and the main eligibility is really based on clinical status. You have to be classified as being an older normal individual to enroll into the study. So many people screen fail at this rate. So they try to get into the study, and then they don't meet criteria for being normal, and then so they're excluded and they never get a PET scan, whereas only a subset, will actually end up getting a PET scan. And then from there, they're sorted into the trial. So we were interested in like, okay, well, what are the rates of failing at this phase before you even get a PET scan? Because the results that we're looking at, they're only the people that ended up meeting criteria. So we actually are throwing out, theoretically all the amyloid data on this screen fail group. So we looked at that data, and yeah, so what we do find is that the non-Hispanic Blacks, they screen fail at that initial stage at a much higher rate than the non-Hispanic whites. When we look at why the screen failure is happening, it tends to be the case that the non-Hispanic Black group has lower scores than the non-Hispanic white group. That's the main driver of this screen failure rate. And this is obviously a problem. So this has been studied and documented many times. So we know that when we look at these self-identified race categories, there does tend to be this intercept effect, such that, so in this example from Lisa Barnes, the Black group is lower than the white group at baseline, but this does not translate to differences and changes over time. And so we also, the main interpretation here is that the measurement is quite poor. In particular, there's a tremendous amount of bias in these tests. There's a lack of appropriate norms, and these tests were not developed, with a diverse sample. So I think effectively what we're doing is we're screen failing, folks that actually, they are normal individuals, and the measurement is just incorrect. So just to highlight, we are the A4 study is screen failing non-Hispanic Blacks at a much higher rate than whites. They go into the screen failure group, and we actually are just left, we just don't know what their PET scans actually would look like. I also want to mention, so with this A4 data set, so it's a huge data set of amyloid PETs. The total number is 4,400. There's really only 3 kind of self-identified categories we can look at that have enough representation. So there's the non-Hispanic Black group, which I just presented. There's also a non-Hispanic Asian group, and then also a Hispanic white group. It is kind of disappointing that it requires 4,400 scans to get 150 scans, but it is nice that there's a decent number to look at these, potentially these 3 self-ID groups. And interestingly, we've taken a quick peek at this in the Asian group, because that's actually the minority group that has the biggest representation. And the pattern is the exact same as the non-Hispanic Blacks. So here's the data I just showed you for non-Hispanic Blacks in purple compared to whites. And here's the same exact pattern if you now look at this in the Asian group. So again, we see this reduced prevalence of amyloid positivity in the non-Hispanic Asian group. And that's consistent across genotypes. It's a little less than the E3s, but still lower. And the screen failure pattern is also exactly the same. So I just showed you for the non-Hispanic Blacks, there's greater screen failure. that's the exact same for the Asian groups. And also the confound of lower scores is also the same exact pattern. So it really has become clear that I think there's these large issues, with just the actual eligibility and data collection kind of phase of these studies that are potentially biasing the data in quite a dramatic way of those that end up getting PET scanned. So I'm gonna summarize and then take some questions if there are some. So I told you guys about amyloid PET. I mean, it's very widely used right now. And I think especially for early detection in the research context, it's a very important modality, and it's being used in many applications, including clinical trials. The integration of tau PET is a more recent tool for us, and it does seem, at least in our biomarker cohorts, to be helpful for predicting who might be most at risk for decline. I think it is interesting. So I showed you that for the most part, tau PET does tend to map on to these kind of composite measures of memory. But I think it's still to be determined what the exact mechanisms are, how exactly this kind of tau signal within the medial temporal lobe and also in these initial cortical regions, how is it actually affecting cognitive processes and neuronal computations. It's also unclear whether we have the sensitivity to detect these kind of tau-related changes before the amyloid positive stage, but I think there is some evidence of that from some studies. And I'll lastly end on this issue with eligibility. So, I think the main criticism of these PET studies, is that they are, it's just, there's a lot of bias in the actual data sets that results. And I think it really highlights, more research needs to be done on this, obviously, but it really draws attention to, even though we have this nice set of findings, there are these huge gaps that need to be filled, which hopefully there will be some progress in that space over the next few years, hopefully, given how common these PET scans have become. And then I'm just going to end quickly by acknowledging a couple of people in my lab whose work I highlighted. So Casey Dieters has been leading the amyloid PET effects in the A4 study that I ended with. Tyler is my RA, who he's been leading most of the work with our local PI tau PET collection. And then Ali is a postdoc, Ali Trell, who's been leading the fMRI studies looking at cortical reinstatement and the association with tau PET. So I will end there, and I'll take some questions if we have time. Thank you.
Okay, that was amazing, Beth.